All right, thank you so much for joining us. We are going to go through today Disrupting the Opioid Epidemic with Data Analytics with your host, John Roach. So I'm just going to do a quick introduction of John, and then I'm going to go ahead and let him get started so we can move things forward. John is our Director of Data Analytics here at KSM Consulting. He leads the team in the evaluation of data to uncover business insights and creative predictive models for business transformation. John has 3 degrees, as you can see here, and he also leads our design thinking sessions quite often. And a fun fact about John is that he uses his engineering background to work on cars. So I'm going to go ahead and wrap things up, let him take it from here, and we'll get started.
Good morning. Brief overview of what we're going to cover, and just as a reminder, we did this webinar I think about a month ago, and that recording is available if you'd like it. Really what we're going to do is there's been a lot of effort really across the United States and the rest of the world attempting to more effectively combat the opioid epidemic. And we were fortunate enough to really get started on this work about a year ago, which was kind of at the very forefront of kind of the latest wave of problems. So what we're going to do is cover some of the approach we've taken in combating the epidemic, which we believe is a very holistic, comprehensive approach at the state level. So we're going to be looking at a bit of how we sort of approach the problem to begin with. Defining and monitoring KPIs and dashboards, which was really part of our effort. A little bit of information on funding opportunities at the federal level and otherwise, and some information on how to get started. And lastly, we'll wrap up with some questions and answers. So I'm not going to spend much time here, but I think there's a sort of well accepted at this point really recognition that the opioid problem is getting steadily worse, and there are lots of causes for that, which we'll kind of dig into. But really, states, the federal government, communities really have to take a comprehensive approach to really get in front of the problem and tackle it where it's starting. So where to begin? We began with data. What we found in performing sort of a literary review across the country was that there wasn't sort of a generally accepted understanding of what was causing the problem and how to combat it. There were lots of different perspectives from siloed points of view. So if you look at opioid prescription rates, I think there's a lot of literature out there about how potentially overprescribing opioids led to the epidemic. There's a lot of work around the efficacy of naloxone and other drugs to triage the problem. There's a lot of work around the impacts of policing the problem on its sort of overall effect on both rates of addiction and rates of death associated with addiction. But really what we looked at was really, what do we need to do to gain a comprehensive understanding of the problem? What initiatives are most likely to be successful? Of those initiatives, which programs are producing results in aggregate? And really, I'll get to the last point first in the outline is where are more resources needed? So looking sort of across the landscape of sort of both the problem and data, we saw lots of questions. So you can see those on the left, really ranging from where the overdose is happening, who are they happening to, what are contributing factors like what pharmacies are losing drugs, what drugs are being confiscated most off the streets, where are positive drug tests happening and who are they happening to, and really where are more life-saving drugs needed from a distribution standpoint. Really what we found was the information really to answer those questions are spread across lots of systems and there are problems inherent to those systems that need to be addressed in order to fully unlock the data and really address those questions adequately. So we think this is probably the most important slide in the whole slide deck. So when we sort of started looking at this problem to begin with, there are really a lot of players needed in the landscape to most effectively combat the problem. So really we see those sort of grouped into four main categories: policing, healthcare, treatment and recovery, and regulatory and policy. And then across those four groups, we really see a need to increase communication, collaboration, and education. And we think data science and analytics can play really a reinforcing and really contributory role toward really informing sort of what communication needs to happen, at what levels, how to most effectively do that, and then in turn evaluate the efficacy of decisions made across those four groups. So when we look at the response framework and kind of take a dive down into what specific organizations and agencies are involved, we really see that Family and Social Services plays a large role. Of course, the Department of Health, of course, Corrections, criminal justice, and then really in terms of evaluating the effects of the overall problem, departments like workforce development and child welfare become very important. In terms of public organizations, we see and have worked with a handful of groups both in the healthcare space and in the general community development space. You see a few of those listed here, both research entities and public health entities. When you take a little bit closer look at the solution we've developed, what we've really done, if you look at the top, are key data sources we've integrated across the landscape of really systems and data that's available. I'll get a little bit in more detail in a second, but we think it's necessary to combine all of those transactional systems in a way that facilitates analysis and reporting. That requires, of course, a good degree of cleansing, standardization, and combination of that data for analysis. When we look at the really four primary mechanisms we're using to really uncover insight from that data, we found dashboards to be very effective in just getting really a first order understanding of the problem. Geospatial visualization becomes very important as we look at sort of the adequacy of treatment and other things across the physical landscape of the problem. Deeper diving dashboards we've found to be really beneficial in looking at how the problem is affecting communities differently. And then, of course, forecasting, trend analysis, and predictive analytics play a huge role in understanding how to most effectively combat the problem. Looking specifically at really those data sources, what you'll see at the top is those are very wide-ranging. Everything from really offender management to criminal arrests to laboratory test data. I think all but one states have a PDMP up and running, a prescription drug monitoring program up and running. And then we move into really the sort of the triage information. So drug overdose treatment records, where is naloxone being deployed? And then lastly, we found it be very beneficial to pull in demographic and other general population information just to understand sort of in a normalized way how the problem's affecting different communities. So we'll do a deep dive now on some work we've done for the state of Indiana. So really looking back, Indiana was really one of the first states to really feel the brunt of the crisis. If you've looked back over about the last 15 years or so, we've seen about a 500% increase in reported opioid overdoses across the state. And over the past few years, which we'll get to in a second, we've seen the nature of the problem change significantly, which is very important because it does affect how to most effectively combat the problem. So looking at Indiana specifically, there were a few high-level goals and then some longer-term goals as well. So really looking at the initial goal, it was to break down information silos among agencies in order to obtain a more comprehensive big-picture view of the problem. Longer term, they want to really implement treatment and prevention programs to most effectively get in front of the problem and both assist those who are currently addicted and ensure that really they have the best chance of avoiding the worst outcomes there. And also, with this comprehensive big picture view of the problem, understand how to most effectively allocate resources and distribute programs across the population so that we can really get in front of the problem and really stop it where it starts. Indiana has taken some policy and really operational alignment steps in order to combat the problem. The largest of those being really the appointment of a drug czar for the state, Jim McClellan. And as you can see, at the really gubernatorial level, it's gotten a lot of attention as well. So why was Indiana so able to respond to the problem quickly? It really comes down to the fact that really twofold. Indiana as a state is a very progressive state and fast acting, which helps. One of the things that they've done really in recognition of the fact that there is this inherent, this inherent hurdle inside of state government with respect to data being siloed in different agencies and systems. The state of Indiana set up the Management and Performance Hub with really its primary goal being to assist the state in better using the data it collects to inform and improve programs and services for citizens. There's a quote there from really the Chief of Staff of the Indiana Management Performance Hub about really his sort of first seat role to the problem as a whole. And really he was at the forefront to really this shift inside of government of viewing data as a strategic asset that could be used to combat problems like the opioid crisis. So looking specifically sort of at the project inside of Indiana, we really created 4 big outcomes for them to begin with. The first was optimizing locations for opioid-specific treatment centers that were federally funded. The second was identifying how to most effectively deploy naloxone across the state to create the largest impact. The third was really lending insight into trends in drug abuse. And the last was really uncovering some previously unknown factors associated with the problem, such as this impact of pharmacy loss on overdose, which we'll get to in a second. What we found was really there were 4 key barriers in place that we had to overcome to most effectively understand and combat the problem. The first was, seems very obvious, just appropriately characterizing opioid-related deaths. We'll get to that more in a second. The second was across many states, multiple entities are subcontracted to perform drug testing, and they don't submit those drug test results in a standard format. So around drug names, volumes, et cetera, a good degree of standardization is needed to perform joint analysis. Third, we found it absolutely necessary to incorporate external data to both sort of normalize and gain a deeper understanding of how the problem is affecting different subgroups across the state. And last, as I mentioned before, combining data across these disparate data sets is really necessary to understand at a population subgroup level how different groups are responding to treatment and what's likely to be most effective for them. Sort of jumping into the technology to accomplish those things, as those of you who work with state data know, when you're facing a problem like the opioid crisis that has a fairly long time characteristic associated with it, data quality problems play a huge role in your ability to understand and link records across data sets. So effectively dealing with those data quality problems and probabilistically, rather than deterministically linking records, we found to be necessary. Second, as I mentioned, standardizing lab test data is absolutely necessary, and we've developed some methodologies to do that. Also, county coroners submit death records, and often what we found is the structured information they use to characterize the underlying causes of death aren't sufficient to understand what actually happened. So as an example, you may look at the structured information around cause of death, and it could be related to heart attack or something like that. And then through reading coroner's notes, you find out that there was drug involvement in the death, which we found to be very important. And then the last I mentioned, getting foundational domain-specific data to ground analytical models is absolutely necessary, and we pulled in data from about a dozen sources we found to be beneficial on that front. We are actively working on this project right now, and actually the first really proactive flags here under key advancements is just about complete. So most states actually use a really anomaly detection technique developed in Johns Hopkins. What we found was, in practice, the level of false positives around those proactive flags at a county level were really just too high to render the tool useful. So we've augmented that with another test to identify really anomalous overdoses across both zip codes and counties to understand when we're seeing overdose levels that might be indicative of a larger problem. Second, as you'll see in a second, really the prevalence of different types of drugs is changing dramatically. And to better inform both law enforcement and first responders to the types of drugs, drug overdoses they're likely to see and the types of drugs they're likely to have to deal with, it's very important to understand how that landscape is changing. Third, as I mentioned, initially we were focused just on triage, as I mentioned, with respect to most effectively locating opioid treatment centers and naloxone. Now we've really moved to what we can do to really help those currently addicted and understand the efficacy of programs and services with respect to curbing their addiction. And lastly, that list of data we shared a few slides ago is, of course, moving in the positive direction toward gaining a comprehensive understanding of the problem, but it'll never be sufficient. So we're actively looking for new data sets that can help us fill in some additional pieces. So looking specifically at the data from Indiana, it was interesting that we see what you see in the middle there is a normalized per the population drug overdose rate. And obviously this is interactive, but it has real data behind it, so we're just showing a screenshot. What we saw was, of course, the urban areas did have higher per capita use rates and overdose rates. But as you'll see in a second, those weren't reflected evenly in the outcomes for those people. As I mentioned, the type of drugs being used have changed really dramatically over the last 10 years. In that plot on the right, you see really the DEA grouping of drugs with respect to positive tests. And what you see is, of course, we've seen a really dramatic, almost exponential increase in the positive test results for opioids and a corresponding decrease in depressants. And then you can see some more detail on the bottom of those sort of specific counts. When we take a deeper dive into opioid use, and this is looking at poisoning deaths, we really do see a pretty dramatic shift in the types of opioids causing deaths. So what we see is synthetic opioids playing a really strong role over the last 2 years in opioid overdoses at a rate we really didn't see before 2014. We also see a significant increase in heroin only. I think what is most troubling to those in the health profession is probably this synthetic opioid increase, but also multiple opioids. Looking across the state, as I mentioned a second ago, what you saw a few slides ago was basically use rates, so that's per capita use rates, were actually highest in the areas of most dense population, which is actually right there in the middle of the state. Interestingly enough, though, we don't see death rates correspond evenly to those use rates, and really see the highest death rates per capita in some rural areas in southern Indiana where use rates are relatively low. We actually used this information to most optimally locate treatment centers and naloxone data by looking at each individual overdose, that person's access to treatment, and really the response time for that overdose to most optimally locate treatment centers across the state. So looking really specifically at those outcomes, Indiana actually had been granted authority by the federal government to expand its opioid-specific treatment centers by 5. Really what we did there was look across the whole spectrum of overdoses and the outcomes for those individuals that overdosed, and really sort of test treatment center locations across the state, and really look at the correlation between access to care and outcome for an overdose to most optimally locate those. Actually, most of them were located in existing facilities that were just sort of enhanced and expanded to more effectively deal with opioid overdoses. I think we've covered these, but I'll reiterate them. So in addition to optimizing locations for new treatment centers, we have provided significant insight into the trends of drug overdoses across the past few years. And also, and some of this we can't show exactly, but looked at the geospatial trends and time-based trends across the state with respect to drug submissions, overdose deaths, ER visits, and other things. We'll cover just really briefly some funding opportunities. So with the federal government through SAMHSA released an opioid-specific grant. It's actually, it's the 21st Century Cures grant that went out to every state that applied for it. And really states now are in the process of really distributing those funds really to both better understand and provide direct treatment for the opioid crisis. What you see here on the right is an example of a more specific grant. It's around rural access to emergency devices for opioid overdose reversals, so really naloxone and other drugs. There are 2 more listed here from NIH. So those are both related to direct treatment and some really development of medication across substance use disorders. Next, we see another one from NIH, really more targeted at really understanding how a handful of drugs are affecting subgroups of the population. I think what we're trying to do here is just kind of give an overview of the types of grants that are available. Grants.gov and some other sources really have great resources for grants around this area. This is another one from SAMHSA that's a little bit more targeted. And another one from the Department of Army. As we mentioned, really the agency, the sort of the breadth of agencies offering grants is really, really broad. What we didn't show was actually there are 6 or 7 very active private funds and trusts that are also dedicating significant resources toward better understanding the problem. I won't name any here, but I think a quick Google search would turn up a handful. And those grants are often more geared toward either running pilots of specific programs in targeted communities to really test and better understand what may work in a specific area so it can be really deployed more broadly across the United States. Or work on sort of assisting in developing a more foundational understanding of the problem. So how to get started? So our team's been working on this problem for about a year. We showed just, I think, a sliver of the work we've done here as the work is really ongoing. And we would be more than happy to meet with you, discuss specifically what you're working on, share more about what we've learned and how to get started. We've also, I believe, done a significant amount of work understanding really the data assets that are available to combat the problem and develop some key technologies to unlock the most value from those data assets. So really looking across really the data available to your organization is something that we feel like can really assist and aid an understanding of the best place to get started. So that is all we had for today. Feel free to submit questions to the chat box on your screen, or unmute and ask questions, and I'm more than happy to address anything you might have.
We do have one question that came in.
So the question is, how did we go about engaging pharmacies to partner in the data exchange? Actually, we did engage pharmacies. So all pharmacies are required by federal law to submit to state government and actually the DEA as well, records of any pharmacy losses. So those get categorized into some major groups. So employee pilferage, that actually separate theft at night or theft during the day, lack of reconciliation in counts. So there are a handful of groups, and each pharmacy is required to submit that information. So really what we did is use those submissions as the basis for analysis. And we didn't quite get to this, but an interesting outcome we saw in looking at that data was that when there was a large pharmacy loss of opioids through sort of whatever means, we actually saw a corresponding echo in overdose rates at some time later. So that was an interesting outcome. So what that's actually allowed the state to do is really for the first time ever, Indiana unfortunately leads the nation in pharmacy loss by volume, not per capita, but by total volume. And what that's enabled really the state to do and the legislature to do is for the first time be able to quantify the impacts of legislation surrounding protection of controlled substances and drugs in order to really inform additional policy around additional preventative measures they might take to protect those drugs. Yep, one more question. So the question is, were we able to identify prescription rates of opioids at pharmacies? Okay, so really we were. So I mentioned early on that the prescription drug monitoring program that the state has really allows us to understand sort of at an individual level and more broadly what was prescribed and what was fulfilled. I will say a significant gap that we've seen around some of these issues is really first, as those of you analyzing the situation probably already know, the prescription fulfillment rates for some life-saving drugs is very, very low. Second, what we found is, we didn't sort of get into this, that there is certainly a gap in the really the non-publicly funded, so non-Medicaid, Medicare data around prescribing non-controlled substances, so those that don't fall into the PMDP or PDMP. So what I mean there is if non-controlled substances are being prescribed for really pain reduction, pain maintenance, we really don't have a good picture of what that looks like. So can't readily understand really impacts on addiction rates for those not prescribing opioids. So we're actually working really hard to get some of that information now. Hope that answers your question.